Hello, and welcome to the show Beyond the Journal, where we discuss social media, digital education, and current controversies and issues in cancer and medicine. I'm Dr. Jack West, Associate Clinical Professor in Medical Oncology at the City of Hope Cancer Center in the Los Angeles area. I'm happy to be joined today by my co-host, Dr. Charu Aggarwal, who's the Leslie M. Heisler Associate Professor of Lung Cancer Excellence at the University of Pennsylvania's Abramson Cancer Center in Philadelphia. Hey, Charu.
Jack. Today we're pleased to welcome Dr. Petros Grivas, who's a medical oncologist at Seattle Cancer Care Alliance and associate professor at UW and Fred Hutchinson Cancer Research Center in Seattle. Welcome, Petros, to Beyond the Journal.
Thank you so much, Charu and Jack. It's a great honor for me to be here with you.
So we would like to start off with some of your work with COVID-19 and Cancer Consortium. This has been really a spectacular effort, collaborative effort in terms of gathering information pretty quickly and disseminating to not just the United States, but the world in terms of what happens and what the impact of COVID-19 can be on cancer patients. Can you talk to us about the beginnings, and did you have a lot of challenges getting centers on board? And, I think you really set a neat example. So take us to the beginning.
Thank you so much, Charu, for this great question. And again, thanks for having me. I would say that the COVID-19 Cancer Consortium has been this highlight, this oasis in this dramatic year of the pandemic. And how it started is very interesting. It started from social media. There was an inherent question, from many of us, using Twitter those days about a year ago, how would we manage patients with cancer if they have COVID-19 or in the context of a COVID-19 pandemic? So that question, that actually was initially posed by a fellow at the time, Dr. Akash Desai, and it became a Twitter discussion that was actually transfused or moved to an email discussion. And this email discussion gave birth to the COVID-19 Cancer Consortium, or the so-called CCC-19. And I can tell you, these days were like all of us interacting, with each other, exchanging ideas. And Dr. Jeremy Warner at Vanderbilt University, who has a lot of background in bioinformatics and also in educational learning and educational platforms. I call him the architect because, he pretty much, he's the man behind the scenes. Although he doesn't admit that. And he pushed us to create this consortium, and many of us met, and we formed this steering committee that has now 11 people. And the steering committee of the COVID-19 Cancer Consortium has been literally, a fantastic experience, a learning experience for all of us, but also a voluntary effort to put things together. We were able to get 128 cancer centers together from scratch, and many of them literally within a few weeks of founding this consortium. The idea behind it is to pretty much using the crowdsourcing method, try to generate rapidly and as quickly as possible data relevant to COVID-19 and cancer in order to help inform discussions, in the clinic or policy makers, stakeholders, about how we make these decisions and policies about patients with dual diagnosis, cancer and COVID-19. I will just end up saying that this was not an easy effort, and definitely, put together the best of us. And challenges were obvious, especially in the beginning. How do we get the people engaged? How do you convey the mission and the vision of this consortium? And how do you convince people to put the time and effort on a volunteering basis? But I think I think everybody was pushed to the limits because of the pandemic and realized the need to generate data and have as much as data-driven approach as possible, rather than just a completely consensus-based. And everybody really chimed in, and we had a huge family of 500 plus investigators. And right now, we wish we had 0 cases, but we approached 10,000 cases in this consortium. So I think all of this knowledge is being disseminated to the community and help make decisions. But it was definitely a matter of persistence and consistency, and also working with the individual IRBs in different cancer centers to try to prioritize this study, especially in the context of COVID-19. And this was one of the challenges, to get the IRBs to approve it, but also the data sharing, right? And many institutions, big cancer centers, were very protective of their data, and some of them still are. So some institutions could not join just because of this huge, I would say, ubiquitous challenge of data ownership and data sharing. But many others were able to forego that, and overcome this challenge and contribute to the database.
I think part of what impresses me about it was how on the fly it was. It's so organic that it just started out of necessity, and it bore real fruit. I mean, you were able to present the data last year, at conferences. You just published, congratulations, a paper on the experience, and it is a very meaningful contribution to the field that I think, for all of the single institution experiences or small consortia of 2 or 3 centers in one region, this is something different that looks and is able to provide a global assessment, compare locations, but just to be able to pool data across different geographies, across different cancer types. It's really impressive, and I imagine that this is going to be a proof of what can be done beyond this question in the future.
Thank you, Jack, for pointing this out. It definitely it takes a team to work, and Dr. Aggarwal and myself were part of this amazing experience of the ASCO Leadership Development Program, the ASCO LDP, and we can talk about that later today. But the skills that we tried to learn and acquire during that wonderful year definitely came handy to this endeavor. And nothing is easy. And when you try to convince people to dedicate time, volunteer their time in a very busy schedule during the pandemic, and also go through the regulatory hurdles, the logistical hurdles, also the legal kind of data ownership hurdles, definitely as I say, help to build the character. But I think it's definitely the amazing example of a teamwork, and nothing could be done without the team spirit. And many people, 500 plus people contributed, and all the success goes to them.
Mm-hmm.
Yeah, do you think that this can serve as a model for research to be performed beyond the pandemic? I think before the pandemic, we couldn't really think about efforts such as TerraVault, such as CCC19. Now ASCO has a very active registry. And really, I think this may spearhead into other efforts. What are your thoughts about, how we will be operating 4 years down the line?
Well, thank you, Charu, for the question. I think that, as you pointed out, there is a number of efforts like CCC19. CCC19 is not the only one. You mentioned TerraVault. You mentioned the ASCO registry that is going on. The NCI study, the NCI CAPS, it's another effort, very important. And the ESMO also is doing the ESMO co-care. So multiple examples, and probably there are others too. I don't want to neglect any. But I think all of them, as you pointed out, set up a new paradigm. I think a new age of research that is more collaborative. I think many of us have been trying hard to get multi-center collaborations with variable degrees of success, but I think the pandemic really made us think through what are the constraints and the barriers to do this in the right way, and is it really a constraint that cannot be overcome? The same thing with telemedicine, right? So I think that this example or paradigm is here to stay even after the pandemic gets under control. I think can lead to more meaningful advances. I think people can work together, and we can work together without seeing each other nowadays, as Jack mentioned before. So I think it's going to become, I would say, more a ubiquitous paradigm of research, and why not being more globally? We tried to engage centers in Spain and other parts of Europe. We were communicating with NCI, ESMO, with ASCO. And I think the key word was coordination. How can coordinate efforts and align, your scope in one direction? There's definitely a lot of challenges. I know in Europe, the ESMO initiative, it's even more challenging because there are different countries involved. So when you try to share data among different countries, becomes almost a nightmare. It's very difficult. But I think we have to work higher up leadership, in policy level and enable research. I personally have been very worried over the years that because of some bad things that happened in the past and should not happen again, research has become very restricted. And of course, it has to be regulated, no doubt about that. But it has to be a balance between feasibility and regulation. And we have to let the research and the science give us the answers.
Can you talk a bit about, I know that you also, beyond the CCC19, have been committed to and lead clinical research in GU Oncology, but obviously the pandemic has really thrown a monkey wrench in our ability to see patients in person, and telemedicine shored up some of that for the clinic, and will probably be here to stay in some capacity. And there has been hope that the regulations that we have in how research get done could be liberalized somewhat to make it more pandemic compatible. But how well has that worked? I mean, has your clinical research been able to push on with modifications, or was everything just put on ice until people can come back into the clinic and resume something like before the pandemic?
Jack, this is another very important and timely question. I can tell you, a few things that happened during the pandemic that were lessons learned. Number one, we definitely tried very hard to create an infrastructure of safety in the cancer center. And this, of course, included, screening in the door, as of symptoms, testing of appropriate individual, physical distancing. And of course, we had to come up with a plan overnight of how to deal with research. And this was not an easy effort. I want to highlight the amazing efforts from my colleagues here at Seattle Cancer Alliance. Dr. Masumi Ueda and Dr. Mark Stewart led a publication at the Journal of NCCN, if I remember correctly, a year ago, outlining our immediate response, because Seattle was one of the first cities to be hit by the pandemic.
Yeah.
Included research. And what we did, Jack and Charu, we came up with a plan that pretty much has a benefit-risk ratio for each trial. So the cancer center said, if you have a phase 3 trial with let's say, an alternative standard of care option that is maybe the control group, you may hold off the trial, because you have a standard alternative that the patients can go to. Or if you have a phase 1 dose escalation, phase 1 trial that you're not even sure about the efficacy, you may hold off that. But we're able to keep on open and accrue very well, I would say, phase 2 trials that serve an unmet need, that, there was a significant, at least anticipated or perceived benefit for the patient. And I think we did pretty well despite the pandemic here, at least in our cancer center. And at least in the GU group, the GU program, we're able to keep about 80% of the trials open with that algorithm. And obviously, we were evaluating week by week based on the pandemic surge and the numbers of COVID-19 cases and patients who were in the hospital. On a global level, I would say that the pandemic, again, forced us to work in a team. And I can tell you that we work well in terms of retrospective data collection, work with multiple other institutions. We have a parallel effort with 20 centers right now in GU Oncology. We contribute data to a database looking at patients with immune checkpoint inhibitors. And one of our previous fellows, Dr. Ali Kaki, who's now in a sub-professor at Stanford, is leading this effort with me. And we're able to be very productive by doing this collaboration, forging this collaboration. And I think these paradigms will continue to exist. The last point I will make is that, looking forward into the future, I think my concern has been that multiple other places were hit hard by the pandemic, and they were also almost forced to shut down clinical research operations for a while. And this created, of course, some consequences. Number one, no access of patients in clinical research and access to innovative clinical trials, as well as potential deviations in clinical research. And the FDA was very proactive about this, like putting out a statement out there to help, and also some data gaps, right? And when biospecimens potentially get lost, visits were not done properly. Obviously, safety comes first, but I think the impact was very intense in some cases. And my hope for the future is, as a vision for the future, I think there have been and will be more efforts to ease some of the regulations, allow, for example, consenting to be done, with no in-person visits, and CCAP studies doing that, I think. And again, with the context of regulation and of course, compliance, I'm hoping we will be able to do more in terms of research, in terms of eligibility, loosen up eligibility criteria, be more inclusive in terms of eligibility criteria, keep the regulations, but also make it more pragmatic and also more inclusive, because the strict regulations may also have some association with potential exclusion in some populations. So we have to think about all this in a balanced manner.
Yeah. I still remember, I think it was February of last year, when I saw some tweets from Fred Hutch researchers, basically saying that, the entry to the cancer center and to the research building has been limited, and they're starting to work from home. And, at that time, middle of February, I think it was, or beginning of February, I thought to myself, oh my God, what's happening in Seattle? Only to realize later that it's coming for us all, and pretty quickly at that. So you really led the way in terms of setting the standard for, how to do things safely, at least in the beginning stages. So we really looked at you and looked at New York for examples. Want to shift focus a little bit and talk about, how you chose GU oncology. Both Jack and I live and breathe the lung world. And it strikes me that there are so many similarities between lung and GU. And tell us about your decision.
That's another fantastic question, Charu. And I can tell you that, going back in the day, even in medical school, oncology has always been in my mind. And specifically, I was very interested in GI and GU oncology. And I think part of that interest was related to the different tumor types that were a part of the both GI and GU oncology. It's not only one tumor type, but more than that. And different, I would say, complexities, different mysteries, as I call them, and different prognosis and outcomes, right? You have, the majority, at least, of patients with testicular cancer do well, thanks to work by the giants, who are still around. But some other, patients may not do that well with that cancer. But patients with prostate cancer is a mix, right, of different outcomes, and with urothelial cancer and kidney cancer also a mix. So this, it was very intriguing to me, and gave some, I would say, plethora of different situations that was definitely interesting. So part of that was that inherent interest I had. To be honest with you, and I think I told Jack in the past, that I did my PhD in colorectal cancer. And my initial interest was that. And I did my PhD, was still back in Greece. And I had a great team there. I was able to work in the lab, learn a lot by smart people. And then when I came here, I did my residency in Philadelphia, Charu, and Philadelphia is always in my heart. And I moved to University of Michigan for fellowship. And to be honest with you, I was influenced by the very amazing mentors I had there. And I was lucky probably, to make a decision early on, because time matters when it comes to research, and the earlier you start, the merrier. And within weeks of starting my fellowship, I just literally, as I say jokingly, saw the light in GU. And I think part of that was the unmet need, especially in the field of urothelial cancer. I was looking at the cases, patients, of course, in clinic, who are the reasons of what we do. And the literature, the field was not moving that fast, definitely not as fast as other cancers. And it was kind of not as well-known and probably underfunded as well. So I saw kind of an unmet need and definitely a challenge there. So I decided to pursue that pathway early on in my fellowship, and influenced by my mentors as well. I definitely encourage all the trainees out there. look up all your options. You don't need to hurry too fast. You want to make sure you have all the data points. At the same time, try to make a decision as early as you can in your first year of fellowship to allow time to be productive and have a concrete plan and mentorship in place. And mentorship is a whole other subject here, but it's a very important part of career development as well.
Well, it's interesting. I think for me, my secondary interest was always prostate cancer alongside lung, different, but in some ways complementary. The outcomes with many people with prostate cancer were very good. One of the big issues is you need to not overtreat as well as not undertreat. And a lot of people, a lot of men who, you really need to think about, is this going to be clinically relevant if this is presenting in a 78-year-old with comorbidities? How much does the prostate cancer bubble up? But it always challenged and bothered me that I think this is kind of old news and it's changed, but for a long time, there just wasn't nearly as much good data, clinical data in prostate cancer. It was more judgment. It was more subspecialty bias. There's a lot of partisanship of radiation versus urologists in terms of, just territoriality of who's going to cover this early stage issue. And a lot of, it seemed to me that a lot of what was done at different institutions had to do with the strengths of the people involved at this place or one place or another. But I think that that's really changed, and there's incredibly more out there, way more data in the last 5 or 10 years in, say, prostate cancer and bladder cancer than there was in the preceding 10 years. So much so that during the earlier part of my career, the medical oncologist was much more of an afterthought coming in late to the party in prostate cancer, at least, that was really dominated by the practitioners of local therapy. Can you talk about just some of the changes that you've been seeing over the time of your career? Because I feel like the momentum has really changed in a lot of GU fields. That is, there's way more focus, interest, research, and data coming out than there was 10 years ago.
Absolutely. I think you have a very big point there, Jack, and you're right. There is definitely a revolution, I would say, in GU cancers, across the board, kidney cancer, urothelial cancer, prostate cancer. It's really, really fascinating. It's even hard for GU oncologists these days to follow along this rapid progress and of change and be, on top of their game, especially, if you're community practices. I really admire my colleagues in community, how much, how hard it is, right? How much difficulty to follow along, not only the different GU cancers, but all the other cancer types, right? So I think the potential reasons for this, let's say, evolution or revolution, I think number one is awareness, alertness, and available funding. It sometimes sounds simple. It doesn't mean that if you throw money into a problem, you will solve the problem. But definitely funding helps, right? So to give you an example, urothelial cancer, bladder cancer specifically, back in the day, it was something that people didn't even know sometimes. If you talk to the community, or even now, we do our virtual bladder cancer walk in a few weeks, and sometimes people say, bladder, what is that, the cancer there can happen? So this awareness barrier, is important, because the more you raise awareness and you make people aware of that, the more you attract interest, and you attract interest from various stakeholders, right? You attract interest, from pharmaceutical companies and industry. And to be honest, major advances in the field happen because pharmaceutical companies and industry were engaged. The reality is that the vast majority of the FDA-approved agents out there come from industry, and we have to admit that. And there's nothing wrong with that. We all want to keep the compliance. I agree. We have to maintain, regulation and disclosures. At the same time, academia has to work with industry. I'm very clear about that, and I think we have to be honest about this on a global level, and through collaboration, right? And of course, keeping the principles, but work together. So more industry, got engaged. More industry was investing, right? And they start doing clinical trials, in urothelial cancer. That was not the case before. So immunotherapy was another big reason. Immunotherapy came exactly at the right time. 2013, I think, was a cancer immunotherapy year, and there was this discussions in Science and early publications. And obviously, immunotherapy comes very handy in urothelial cancer. We follow the examples that you guys said in lung cancer. We usually follow a year or two later what you guys success, and we try to replicate it. We learn from you. And because of the biology of urothelial cancer, high tumor mutational burden, potential immunogenicity, immunotherapy appeared to work, not in every patient, but in many patients. And I think this was a big reason why the field went forward. The third reason was molecular biology. Before the TCGA projects came about, before 2014, I remember, because I was honored to be the discussant, in the TCGA bladder cancer presentation at ASCO annual meeting that time. There was not much knowledge about the molecular biology of disease, the different mutations or other alterations that bladder cancer may have. So when this TCGA data came out, along with other molecular data sets from different academic institutions and either commercial vendors, we started to dissect the biology of disease. And this came, together with a pharmaceutical company interest, and look at targeted therapies. And now we have, within the last 5 years, we have 5 immune checkpoint inhibitors approved in advanced urothelial cancer. Two of them were recently withdrawn for platinum refractory disease, but still a lot of immunotherapy there. And also we have a targeted therapy for the first time, an FGF receptor inhibitor. So I think the combination, the right time, the stars aligned, and also there was huge work, of awareness by the Bladder Cancer Advocacy Network, the BCAN. We call it the beacon of light, beacon of hope. And I can't emphasize enough how much work this group has done, advocacy group, patient advocacy group, to raise awareness and go and advocate at the NCI level, at the NIH, to the Congress. We need funding for bladder cancer. And this helps. The more funding, the more you can attract investigators. So more people get into the field, right? And we definitely want more people, right? The more people, the more minds, the higher chance to solve the problem. So I think the GU community is growing, and particularly the bladder cancer research community is growing. And I'm hopeful that in the future we'll have even more successes and keep up the momentum as we do.
Yeah, I was looking through some of the trials that you're running, Petros, and it looks like you're running adjuvant immunotherapy trials in bladder cancer now. And, it's true that it follows a couple of years behind lung, because I think we are soon going to see the readout of some of the adjuvant immunotherapy trials in lung cancer. So it'll be very interesting to see how the data matures for bladder cancer as well. It's really been terrific to see the amazing enthusiasm around GU oncology and, ASCO GU, as well as, targeted therapy, which has really taken off. I want to talk to you about, you talked about the value of mentorship. You've certainly had amazing mentors, and you act as a mentor to, many, many, many people. And you're certainly a peer mentor to me, and you've really helped. So tell me, how has this year changed how you think about mentorship, and have you done more virtual mentorship and in other forums?
Thank you, Charu. I have to start by saying I'm being mentored by you as well, and we learn together, and it's an exciting time. And I think mentorship is a way of living, right? And as both you and me recently, learned during the ASCO LDP, that giving feedback and receiving feedback is very critical, for our career developments and our lives in general. So I can tell you that this evolved very organically for me. So when I was at the University of Michigan, I was very honored to have amazing mentors there. Then I moved to Cleveland Clinic, in 2014, and still had great mentors there as well. And as I started kind of, branching on my own, sort of speaking, still with the context of great mentors, I had the opportunity to work with great fellows. And this evolved so naturally that, I had always an interest in teaching. I can tell you that it might have to do with my father, who was a teacher for almost all his life, and I think his love about teaching, it was definitely inspirational to me, and I can still remember his face, how much it lit up, with when a student learned something or did something good. So I think this came naturally to me, and when we had great fellows and great residents. One brought the other, and without realizing it, we had a fantastic group of mentees at the Cleveland Clinic, and all of them did so well. The fellows, became some professors. The residents became fellows. But I think that the things that the take-home messages for this discussion is, number one, you have to care about mentorship. You need to realize how important it is. And it's not about you, it's mainly about the mentee, but it's a mutual relationship. I have learned so much from my mentees myself. They have made me a better physician, a better scientist, a better researcher, and they still do. The second thing is to have to make time. We're so busy every day, right? We have a million fires to put out, but you have to create time for the mentee and sit down with them, and make a plan. Write a plan, ideally something in paper or in email, something that, has concrete milestones that, have deliverables that have to be met, and they have to be realistic. It's a balance about, how much you want to do, ideally, and how much you can do. But having a realistic plan and with some timeline is key. And also know your goal. I will quote my father again, if you want to go to your destination, you have to choose the right strategy. So make sure you do frequent checks in between. And, now with mentees, we set up, a bi-weekly call or a monthly call. And we frequently check in, and also access, right? They know they can access any time, and I can vice versa. In terms of the same continued at University of Washington with fantastic mentees here too. But to your point, the opportunity nowadays is to do a mentorship virtually, and I'm very honored, and I would say, to be able to mentor some junior colleagues from far away. Some of them, to be honest with you, I never met them in person, believe it or not. That's the beauty of our world, right? And the virtual world that Jack mentioned before, and you mentioned. And there are colleagues, for example, in Boston, in Harvard Medical School, or even in Greece. And, since you all know, my Greek origin is always clear when I give a talk. And it's great to see, people from other countries talking about inclusivity, right? Give them opportunities. And even we had observers from Spain who came over and had an observership here at the University of Washington, from Greece, and hopefully from other countries too. I also, was honored to volunteer for the ASCO IDEA Mentor Program, and that's how you meet people from all over the world. And I think that mentorship concept will continue to evolve, and we're now doing some summer schools in Greece, for graduate students, postgraduate students, and I hope one day I can get both of you over there and help us mentor people with your amazing expertise.
I'd like to turn to another issue that you've been focused on. Obviously, it's important in immunotherapy for bladder, for so many other areas of cancer, that it's really revolutionized a lot of oncology is immunotherapy, but we also face toxicity challenges with that. And my understanding is that you have been part of a consult service on managing immune-related adverse events. A friend of ours, Jarushka Naidu, who was until recently at Johns Hopkins, had pioneered a multidisciplinary consult service that got pretty busy doing this. And I think it's a really exciting, novel idea. I'd love to hear your impressions of what's worked well about it, maybe what may be challenging about it, particularly in terms of, obviously, immunotherapy is used not only at the larger tertiary care centers, but in the rank and file community. And does this mean that patients are going to need to, go travel to the larger centers to get managed, or is this something that might be exportable geographically through telemedicine? So what are your thoughts about where it is now and where it might go?
Thank you, Jack. Great question. And I know Charu is aware of those efforts because we discussed that before. So number one, I totally agree with you that there is a huge need about immunotherapy-related adverse event, proper education, recognition, diagnosis, and management. This has to go through the whole spectrum. The providers team, we all learn every day. There's more and more to learn about immunotherapy and the potential toxicity and efficacy. Also, the team, the nurses, the advanced practice providers, and the patient. And this is important because the patients sometimes may tend to underreport, especially if they do well on a treatment. They want to stay on this treatment, and they have the fear that you may take them off if they have a side effect. So proper education about pros and cons, benefits and risks cannot be overemphasized, and it should be done sometimes 2 or 3 times because people forget, right? Patients sometimes get overwhelmed. So emphasis on education and of course proper management. On the management aspect of it, Jack, I can tell you again, the mentorship come to play here. When I was at Cleveland Clinic, a number of stellar colleagues of mine, along with me, had this initiative to organize an immunotherapy-related adverse event tumor board at the Cleveland Clinic. And that actually was a little bit before I moved to Seattle. And when I came here to this institution, I started, I will quote the ancient Greek again, the Socrates, right? I was going around and I was, trying to get interest from people, guys, can we get an immunotherapy adverse event tumor board here? We need that, I need help. I need to learn, help me to learn, learn together. So I was lucky enough because, generated enough critical mass and great support from colleagues and the institution. And within a few months, with the help of Dr. Thompson, who is actually the senior author of the NCCN guidelines for immunotherapy, and other colleagues, Dr. Bhatti and others, many others, and the service manager here at the institution, we set up an immunotherapy-related adverse event tumor board that is a fantastic learning experience for us. And we do it once every month or once every 2 months. And that's where the challenges come, Jack, how frequently can you do it, right? And how much time you have in a day, and who's going to run this tumor board. So we're lucky enough to talk to fellows, and I have been honored to work with 2 of them so far, Dr. Kennedy and Dr. Kamat, who pretty much they run the tumor board. And it's really amazing to see them, take ownership of this and literally, take it to the next level. And, it just goes back to mentorship. Sometimes I'm sitting in the back of, in the Zoom room, and I see the fellows signing by running the tumor board. That's great. And we will have cases. Obviously, the challenge there is the time to management, right? If you need an answer right away, the tumor board will not happen by, within like 4 months from now. So we need, how do you address that? So the other initiative that we took as a team here, we established what we call a listserv email list. And we just started having this work very nicely 3 weeks ago. So what happens is you're in the clinic, Jack, you have a patient and you need an advice right away. So similar to what Dr. Naidu did very nicely in Johns Hopkins, the provider sends an email quickly to this listserv, and they don't put any PHI, but they ask for the specialty that is needed, pulmonology or rheumatology, and everybody. We have representatives from all the groups now. We went out and we sought, volunteered, participation from all the specialties, from cardiology, neurology, all the medical specialties and beyond. And we have 2 or 3 people or 1 person from each of them, and people respond right away. And people get feedback right away, and they can also route referrals fast, so they can get an instant opinion, and then the patient can be seen the next day or the day after by the relevant clinic. The third thing we did was a rheumatology colleague, Dr. Singh. She has amazing energy, and she set up a rheumatology clinic for IRAEs. And she does this once every 2 weeks for now. We set this up from scratch. And we set up a referral mechanism so we can reduce the time for the referral. We try to open this up to the community oncology. So I love to do outreach. I love to go out there. Before COVID, I used to do that a lot. And meet oncology colleagues and primary care providers. And we have them call in to our tumor board. And when there is, of course, we have to maintain compliance. So follow HIPAA regulations, but they can call in and they can present a case, anonymized case. So we try to pretty much make it accessible, to the community, Jack, because I agree with you. It's very challenging when you have a patient, living, 4 or 5 hours away, they get to a local hospital. How can you establish a channel of communication in the middle of the night or when the medical record may not communicate? So challenges still exist. It's not perfect, but we try to tackle them one by one as a team.
Great.
I can only imagine what a fantastic educational opportunity this must be for fellows. I think one of the things that we can teach them and really leave them with is the, power of immunotherapy, but also, that it is a very powerful set of drugs that can lead to fatal toxicities if not recognized early. So congratulations on that effort. And yes, I did hear about it very early on when you were just thinking about this as an idea, and was thrilled to hear that it was executed, and now to hear about how big it's become. This is fantastic, Petros. Thank you so much for joining us today. It was really terrific to have you on our show. You can find us on iTunes or wherever you find your podcast content. We hope that you will subscribe and send us comments and feedback to beyondthejournalshow@gmail.com. We thank Mark Lindsay and Talking Speaker for production and distribution support. See you in a couple of weeks with our next guest. Thank you, Petros.
Thanks, Petros. Great talking to you.
Thank you so much, and thanks for all you do. I appreciate it.
Excellent.